Witono is my my son-in-law. Witono.
Oh, really? And
Yeah,
this
my son-in-law. Maybe sometime
yeah.
I'll send him to your clinics.
Yes, bring
Okay,
all family and come.
Learning from the expert, the magicians.
You are all welcome to Cairo anytime.
Yeah, okay. Nice to hear from you. You are looking good. You are looking good.
Oh, I'm just missing you, my friend. Missing you a lot.
You very much too.
How is the situation in Indonesia now?
In Indonesia, we still the curve is still
curfew.
Growing up. Yes, still.
How many hours the curfew?
Pardon?
How many hours the curfew?
What do you mean?
I mean the curfew for how many hours? I mean they allow you to go outside home from what time to what time?
Oh no, it's okay, but it's only for emergency reasons. For health it's okay. For health provider it's okay.
No school, no government office?
No.
Okay. Hopefully when things will be fine, inshallah, we will arrange the training program with the university in Makassar.
Okay.
I think that will be maybe after September, maybe.
After September, hopefully. Yeah, hopefully we can.
Inshallah.
Yeah.
Inshallah.
Maybe.
Okay, how many registration we have today?
320. 320.
Excellent. Okay, good.
All over Indonesia and some from USA, Canada, Brazil, Switzerland, Morocco, German, Tajikistan, India, Singapore, Australia, Iran, Spain, Croatia, and Myanmar.
That's an international webinar. Good.
International, worldwide. Okay.
I want to test the video again and tell me if you can listen to my sound while I'm speaking, while the video is going, because the music might.
Okay.
You listen.
That is not my flag. That is not my flag. It's Japanese.
Okay.
Now,
can you hear my voice plus the music?
Yeah.
Okay. Because I don't want the music to be very loud, all right? So people can listen to me as well.
Okay.
Good. And so I will make a, can you read this?
Yeah, are you ready?
Apakah Anda sudah siap? Correct?
Ya, apakah Anda sudah siap? Ya, good. Okay.
Sometimes the presentation كده قلب اللي بعده. لا أنا عايز أطلع بره. Okay. Good. So طب بص يا يوسف عايز أفتح السكرين دي إزاي؟ أخلي دي الأساس. أيوه. هو ده؟ لا اقفل ده. اقفل. أظن هو ده. أيوه. طب لا هات صورتي أنا بقى. عايز أقعد على المكتب واظبطني ثانية واحدة.
Gimana kita terima semua atau belum dulu? Biar dulu masih tes tuh. Hah? Ini lagi masih ngomong? Hah?
Ngapain kira ازاي دلوقتي?
Okay, shall we start now, Osama?
Yes, I will be ready in 3 minutes, okay?
3 minutes, okay. Okay. Wah, dipakai ini tempatnya. Kita masih jauh-jauh. Dia di rumahnya nih. Oke.
Dok, partisipan enggak apa-apa dikasih waiting room saja, Dok?
Di waiting room dulu sebentar, 3 menit lagi ya. 3 menit lagi ya, Tina. Setelah saya bilang ready baru dibuka semua ya.
Iya, siap.
Pak Dekan sudah ada, Pak Dekan?
Pak Dekan? Belum ada, Dok.
Ya, belum. Mana mau ready? Bagus ya suara saya sudah jelas benar. Apa? Apa? Siapa? Blok. Hello, Osama. Hello, my friend. Where are you? Hilang. Harus bilang, saya sudah bilang sih kapan aja kamu boleh pakai.
Tapi dok Edi, tapi dok untuk videonya itu kita udah upload di YouTube juga sebenarnya dok. Halo?
Ya, gimana? Sorry, tadi unmute. Ya, mute. Halo,
Oh, ya.
Kamal awal ya.
Ya, itu videonya dok, untuk video yang paduan suara itu kita udah upload di YouTube juga dok. Mungkin siapa tahu videonya bermasalah waktu kita tampilin di Zoom dan mau dilihat kembali, bisa dilihat di YouTube nanti dok. Kita kirimkan
Bagaimana caranya?
via chat.
Saya nggak tahu, mending buka dari sana aja deh Pak, saya nggak ngerti. Bapak kasih tahu aja gimana, saya nggak tahu Pak. Chat kan bisa dari sana juga. Bapak
Oke,
dari sana aja. Ya,
Oke.
saya nggak ngerti
Ya,
Pak.
Oke, siap dok. Nanti saya yang sampaikan dok. Ya.
Ya, oke.
Oke.
Film saya
Siap,
bagus kelihatan. Bagus, latar belakangnya bagus. Segini.
Laptopnya kali ini mundurin.
Oh, lupa jual.
I'm ready, Eddie.
Hello. Sorry, Osama. I use some of your slide.
Sure,
Is it-
it's my pleasure.
Yeah.
I am all yours. You can use everything in my life except my wife.
Okay, thank you very much. So you are ready now?
I'm ready, my friend.
Okay, we start to the living room. Yeah, okay. I admit all the
You see me
participants.
well? Hear me well?
Yeah, very good.
Good.
What about me? It's okay?
I have the Loak coffee.
Yeah, your coffee. Okay, thank you. You can see my video now?
No, I can see only you.
You cannot see my background? It's from Flinders Street, Melbourne, with Peter Maher.
Okay.
With my
your
friend Peter Maher.
Image or a video?
Oh yeah, image. Oke. Oke ya. Oke Pak Awal bisa di apa namanya? Share screen-nya. Please your screen, stop your share screen.
I stop the screen. Okay, just a minute.
Oke, thank you. Kenapa nih? Ih, biar aja. Oke, already.
I want
Yeah.
to stop. How
Yeah.
to stop your screen? Okay.
Oke.
Share screen.
Pak Awal bisa di-admit semua Pak Awal?
Is it
Pak
now
Awal?
stop?
Ya bisa dok, nanti saya bantu.
Oke ya Pak, Bu Tina tolong di-admit semua peserta ya. Kasih tahu saya kalau sudah ada Pak Dekan ini supaya bisa kita mulai.
Iya dok.
Is it okay now? Share
Yeah,
share
okay.
screen stop.
Untuk
Ya,
sharingnya
already.
Dokter Osama
Stop already.
sudah stop dok.
Ya, memang sengaja saya suruh stop dia. Nanti kan saya kasih tahu kapan dia masuk. Oke.
What you want me to do now?
Bahasa Inggris.
Waiting for the dean. Waiting for the dean.
Oh, this is Indra.
Hi, Indra, how are you?
Indra.
Nice to meet you.
How are you, Indra?
Very good, very good.
I want to cut my hair, Indra. I want to cut my hair again.
Sure.
You remember?
Yes.
How is family, wife, and children, and father, and mother, everybody okay?
Everybody okay.
Good.
Thanks.
Udah nyala ya? Udah nyala.
Balik buat buka. Ya.
Tunggu kakak out ya. Tunggu kakak out ya.
Iya.
Nanti jam-jam berapa ya? Jam 5 atau jam 6?
Tono. Mana caranya? Begini. Kata apa beli malah hilang nih? Mana dia?
Hi, Eddie, do you hear me?
Yes. Yes.
You want me to mute?
Yeah,
You
yeah.
want me to mute or unmute?
Mute first. Okay. Oh, halo. Kalau Pak akan masuk kasih kabar lihat dari tadi. Kalau udah langsung terima ya. Dia sudah mau masuk dari tadi. Oh, udah.
Assalamualaikum.
Oke, kita mulai aja. Oh, udah mulai ya. Oke.
Ya, Dokter Edi silahkan dimulai, Dok.
Oke. Suara saya sudah. Oke, selamat sore. Yang terhormat Bapak Dekan Fakultas Kedokteran Universitas Hasanuddin, Profesor Budu, spesialis mata konsultan. Yang terhormat Vice Dean, Wakil Dekan Dr. Rina Masada. Yang terhormat Kepala Bagian Obgin FK Unhas, Profesor Sahrul Rauf. Yang terhormat Ketua Subdivisi FER, Profesor Nusratuddin Abdullah. Yang terhormat para guru besar, baik di lingkungan Universitas Hasanuddin maupun dari beberapa universitas di seluruh Indonesia. Bersama kita di sini juga ada Prof. Wahyu dari Kolegium. Kemudian ada Prof. Yakub, saya mau menyapa Prof. Yakub dan Prof. Wahyu kalau sudah masuk. Saya mau melaporkan di sini dari peserta dari webinar international webinar ini ada 319 registran berasal dari seluruh Indonesia, mulai dari Medan sampai dengan Papua. Dan juga ada beberapa peserta dari luar negeri, dari USA, Kanada, Brazil, Switzerland, Maroko, Jerman, Tajikistan, India, Singapura, Australia, Iran, dan Spain. Sebenarnya ada beberapa juga dari China, tapi berhubung di blok katanya, jadi agak sulit mereka untuk bisa connect ke kita. Terima kasih banyak atas kesempatan yang diberikan kepada saya untuk memandu acara international webinar ini yang merupakan kerjasama antara bagian Obgin FK Unhas dengan Kasr El-Aini Hospital Cairo dengan Profesor Osama Shauki. Let me greet my international friends and participants. Thank you very much for attending this international webinar. I am very pleased to welcome you all into this practical strategy to master hysteroscopy and intrauterine surgery webinar lecture organized by our Department of Obstetric and Gynecology, Hasanuddin University. With us now is Professor Budu as the Dean of the Faculty of Medicine, Hasanuddin University, and Prof. Wahyu, past President of IGES, Indonesian Gynecology Endoscopy Society, and past President of APAGE, Asia Pacific Association for Gynecology Endoscopy. We have already 319 registrants that come from all over the Indonesia, from Medan, from the west, very west, and to the east, the very east, Papua. We have also the participant worldwide from our friend ISGE, IAGL, American Gynecology Laparoscopy. This come from USA, Canada, Brazil, Switzerland, Morocco, German, Tajikistan, India, Singapore, Australia, Iran, Spain, Croatia, and Myanmar. First of all, I would like to thank our medical faculty dean, Professor Dr. Budu, ophthalmologist consultant, PhD, for his support to the international webinar lecture. I would like also to thank our Egypt colleague, Osama Shoki, my friend, in whom also known as a magician, hysteroscopist. May his knowledge and experience lead us to better understanding our hysteroscopy potential in both diagnostic and therapeutic intrauterine procedure. In this webinar, we may notice there are so many our colleagues that come from all over the world. Thank you to all. We all may expect this webinar will give us better understanding of hysteroscopy role in daily gynecology practice. As we know, the hysteroscopy is one of minimal access gynecology interventions performed by direct visualizations of intrauterine cavity and pathology. Hence, hysteroscopy may act as key role instrument in performing intrauterine intervention by delivering maximizing benefits and minimizing side effects to the patient compared with our other approaches. Lastly, we hope that this webinar lecture would give us a chance to share experience from one to another in order to apply excellent hysteroscopic procedure in our daily practice. Thank you all. We come to the second session. That is the choir from our residents in obstetric and gynecology, Faculty of Medicine, Hasanuddin University. Please, for the video, Mr. Awal. Awal, Tina, okay.
Dok, pasien apa aja dok?
Ada 5 pasien PDP.
Periksa pasien, ada 2 di UGD, PDP.
Ada 2 pasien PDP.
Ada 3 pasien COVID. Ada 3 pasien COVID dan 2 masih PDP.
Ada COVID-ku 3.
Ada pasien COVID 2 di belakang.
There comes a time when we hear a certain call, when the world must come together as one.
There are people dying, and it's time to lend a hand to life and create this gift of all.
We can go on pretending day by day that someone somehow will soon make a change.
We are all a part of God's great big family.
And the truth, you know, love is all we need.
We are the world, we are the children, we are the one who making brother a day. So let's start giving. There's a choice we're making. We are saving our lives. It's true, we'll make a better day. Just you and me.
Pasti bisa melaksanakan itu. Kita pasti mampu menangani itu. Terima kasih.
Send them your heart, so they know that someone cares.
So that guys,
you. Applause for our residents. Okay, the next is opening speech by our Dean, Profesor Budu, ophthalmologist consultant. Silakan Prof. Budu.
Makasih Dr. Edi. Assalamualaikum warahmatullahi wabarakatuh. Dan selamat sore. Saya mewakili Fakultas Kedokteran sungguh mengucapkan penghargaan yang setinggi-tingginya atas webinar internasional ini di tengah-tengah kita masih dalam suasana pandemi COVID dan juga dalam suasana baru saja pasca Lebaran, tapi tetap kita melakukan ini dengan sangat baik. Saya lihat pesertanya sudah ada masuk, sudah ada 100 yang masuk. Mudah-mudahan nanti bertambah sampai 300 seperti Dr. Edi sampaikan tadi.
320, Prof.
Yang saya hormati Kepala Departemen Obstetri dan Ginekologi, Prof. Sahrul Rauf. Kemudian tentu para pengurus POGI, Selatan dan juga cabang Makassar yang saya hormati. Kemudian para guru besar, dosen, dan tentu seminat kita yang tentu sangat berkepentingan lewat webinar internasional kita pada sore hari ini. Dan seperti Dr. Edi sampaikan tadi bahwa beberapa kolega kita dari Jakarta dan dari berbagai daerah, mohon maaf saya tidak sebut satu persatu, tapi saya mengucapkan terima kasih atas kebersamaan kita sekalipun ini dilaksanakan di Makassar, tapi sepertinya ini dibuat sangat luas hingga sampai ke internasional seminar. Jadi saya ingin menyampaikan bahwa saya baru saja menyampaikan webinar internasional ini ke tim World Class Universitas dan langsung merespon bahwa tolong seminar ini di-adjust sebagai international conference by virtual. Sebab memang saat ini universitas lagi mendata kegiatan-kegiatan internasional. Berhubung tahun ini hingga tahun depan, Unhas mengumpulkan poin-poin yang penting dalam hal masuk ke dalam jajaran universitas berkelas dunia. Tapi pada saat bersamaan kita tidak on-site melakukan konferensi internasional, sehingga Kementerian Pendidikan dan Kebudayaan mengadjust bahwa webinar internasional yang dilakukan dengan ramai seperti layaknya ini itu akan sama saja nilainya on-site konferensi internasional. Jadi saya sungguh merasa sangat berterima kasih. I would like to greet our speaker from Egypt, Cairo, Dr. Osama Ahmed. Thank you very much for your time to join and to be speakers in our international webinar. I hope this webinar will be a gate for us to initiate collaboration together between Indonesia, especially Makassar and Cairo. And we're very happy because so far, all of our collaboration, even in each department and also in faculty, we generally have international cooperation, not in like Cairo and Egypt, but we know deeply that Cairo and Egypt, an expert from Egypt and Cairo is a very international and very deeply in technology. So it is very important for us, especially for high technology. We know that the hysteroscopy and so on, it is the one side for maybe the technology in the era of 4.0. So this is surely very important for us, especially for our community of obstetrics and gynecology in Makassar. And let me also to put my greet from the participants from around the world. I heard from Dr. Eddie that there are many participants join in our international webinar from Germany, from Singapore, surely from Egypt as well, and also from Tajikistan. This is very far from here, but this is online and virtual conference. It can be joined by around the world. Surely, I hope that our international webinar today will be continued in the others time, even in the virtual conference or in on-site international conference when we have leave this pandemic COVID-19 in the next future. Thank you very much for our great speaker, Professor Osama Ahmad from Cairo, and all of our participants around the world. Sungguh ini tentu sangat bermanfaat bagi kita, dan sekali lagi kita akan masuk ke dalam suasana teknologi. Tentu bagi obstetri dan ginekologi sangat kaya dengan intervensi-intervensi yang terkait dengan teknologi-teknologi virtual, tentu intrauterina dan lain sebagainya, operasi-operasi yang sudah menggunakan teknologi-teknologi sangat smart, itu tentu departemen kita ini sangat dekat dengan teknologi. Oleh karena itu, memang saat ini kita harus terus-terus mencari kolaborator di luar untuk bisa menjadi bahagian dari kita. Karena di zaman teknologi ini, di zaman virtual ini, di zaman digital ini, tidak ada lagi batas antara kita dengan teman-teman di luar. Saya rasa teknologi begitu dekat dengan kita. Tinggal kemampuan kita untuk membuka diri, mau mengakui kehebatan orang lain, dan kita juga tidak sungkan-sungkan, dan jangan kemudian merasa karena kita ini ada di eastern part of Indonesia, kita tidak bisa, tapi kita sama dengan semua di Indonesia, bahkan di dunia ini. Kita tidak punya batas lagi. Yang cepat, yang punya literasi, yang cinta teknologi, itulah yang akan menjadi bahagian dari suasana revolusi industri 4.0 ini. Saya kira demikian, dan selamat mengikuti webinar bagi teman sejawat, adik-adik kita, para peserta pendidikan dokter spesialis obstetri dan ginekologi. Ini sungguh sangat bermanfaat. Ini akan membuka view the future of kita, dan kita tidak boleh gagap teknologi, karena kita adalah hidup di pendidikan dan pelayanan yang sudah syarat dengan teknologi. Saya ingin menyampaikan di akhir kata sambutan saya ini bahwa rumah sakit kita, Rumah Sakit Universitas Hasanuddin, Rumah Sakit Wahidin saat ini mendapatkan bantuan dari bantuan semacam JAICA kalau Jepang, tapi ini bantuan dari Jepang, KFW, itu untuk memiliki gedung yang bagus dengan teknologi yang tinggi, sehingga memang kita harus mempersiapkan diri kita untuk memasuki era ini. Saya kira demikian. Tentu saya sangat bersenang sekali, terus terang sekali lagi, karena saya mencet, saya termasuk tim WCU University, dan saya melaporkan international webinar baru saja ini, dan Ibu Rektor sangat mengapresiasi dan menyampaikan kepada Direktur International Collaboration in Us untuk dicatat sebagai salah satu notes untuk internasional. Saya ada di sini kolega saya, wakil dekan bidang riset, publikasi dan international collaboration, Dr. Rina Masada, tentu akan mengatur semua dan mencatat ini sebagai bahagian dari kerja internasional kita. Dan ya, saya terus terang menyampaikan di sini bahwa Departemen Obgin kita lah ini yang pertama melakukan webinar internasional di zaman COVID ini. Sehingga ini tentu akan saya bicarakan dengan teman-teman di fakultas untuk menyampaikan ke departemen lain agar melakukan hal yang sama, supaya kita bisa semakin international oriented program lah begitu. Demikian saya kira, once again from us in Faculty of Medicine, the Dean of Faculty of Medicine, greatly put our gratitude for our speaker from Cairo, Professor Osama Ahmad. One again, thank you very much, and we hope for the next future we will be done again, the webinar international like this, to strengthening our international collaboration together. Terima kasih para peserta dan para petinggi-petinggi kita dari Jakarta, dari POGI di Jakarta, dari seminar kita di Jakarta, dan dari seluruh Indonesia, dan seluruh peserta yang saat ini sudah ada di saat ini. Terima kasih. Mohon maaf jika ada yang tidak berkenan. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Prof. Budu, for the opening speech. The next is the symposium sessions. Thank you very much for the opportunity to chairing these sessions. I will be the moderator and the first speaker. So my presentation is, okay, sorry. Okay, hysteroscopic at a glance. My name is Edi Hartono, Department of Obstetric and Gynecology, Hasanuddin University, and the International Society for Gynecology Endoscopy, or ISGE member 2017 until 2021. My topic is hysteroscopic at a glance. Okay, hysteroscopic comes from the words hystero, that means uterus, and scopein, which means explore. So the hysteroscopic is the procedure or the method to explore the uterine cavity that we can see, not only see, but we can treat the pathologic finding in the uterine cavity. Pantaleoni is the first hysteroscopic in 1869. That day, maybe it's only for the hysteroscopic diagnostic. The improvement of lens system, inventions of pumping system, and instruments changed the hysteroscopic to panoramic model. The panoramic visualization need medium for distancing uterine cavity. The distension media we can have with the gas or CO2 and liquid. Liquid divided into non-electrolyte like glycines, 5% mannitol, sorbitol, that is the hypotonic one, and the dextran 70 or Hiscon. This one is the high viscous and hyperosmolarity and hypertonic. And the electrolyte like ringer lactate and normal saline. Yeah. So the procedure is we mix with the instrument hysteroscope with the telescope, camera system, and the monitor, and the light source. This one is for diagnostic or hysteroscopic diagnosis. And the working channel, scissors, forceps, and resectoscope, and energy source for the operating hysteroscopy. And don't forget, we have to distend the uterus by the delivery, the distension media with the pump system. Okay. The very simple one for delivery the distension medium, we can use the gravity assisted, or we can just say hanging drop with the infusion set here, the bottle infusion with natural NaCl, natrium chloride, or sodium chloride, and with the infusion set here. Or we can use with the pump, pressure bag or blood check manset, and we can pump this until the measure we need. So, and the automatic one is very safe with instrument or others instruments. This one is the camera systems, camera with the light source and the monitor. Okay, this one is the instruments. Yeah, this is for the diagnostic hysteroscopy. We insert the telescope here with the channel here. Insert this, and this one is the inflow for distension media. As we know, uterine cavity is very small, so we have to distending the cavity so we can see what is inside the uterine cavity. So we insert the telescope via the vagina, and then we come to the external cervical os, analis cervicalis, and internal cervical os, and then we come to the uterine cavity, and then we can see all the room in the cavity room, in the uterine cavity. For the operative one, for the surgery, we can change this channel with the operating channel here. The operating channel, that we can change the telescope here, insert here, and this is this inflow for the distension media, and that one is the outflow. And we can insert the instruments like this. For this one is the scissors, or we can choose with the biopsy, forceps, or others. And this one is the resectoscope. The resectoscope, with this one is the wire loop. This one is the roller ball or the needle. We can use either monopolar or bipolar one, the energy source. Yeah, this one is the resectoscope. It's the wire loop here. Yeah, you see, this one the wire loop. Okay, and that one is the roller ball. This is for DUB or endometrial hyperplasia. Okay. Why hysteroscopic? Hysteroscopic is the gold standard for evaluation, the endoscopic evaluation. Okay. And allows visualizations of endocervic, endometrial cavity, and tubal ostia. Hysteroscopic may be performed in an office setting or in the operating room. Nowadays, we we move from the operating room to the office setting, even in our private practice or in our practical private office. What can be seen and straight? Okay, this one is the normal findings of the hysteroscopic. We can insert by vagina, via vagina, come into the external cervical os and to the canal, cervical canal. This one is the internal cervical os, and come to the uterine cavity. We can see all the pathologic finding here. We can see the tube, fallopian tube, ostia. This was the right one, and this one is the left one. We can use for lysis intrauterine or synechia like Asserman, or we can remove submucous myome. Oh, sorry. Yeah. Sorry. Yeah, this one is the Asherman syndrome. So we have to cut out adhesiolysis. This one, the adhesions between the uterine wall. So we cut it to make it wider, the uterine cavity. Yeah, we just cut with the mechanical one using the scissors. Yeah, this can be with the mechanic only, not surgery, not electric source. Okay. So this one is adhesions for the Asherman syndrome. Okay. This is the TCRM. TCRM means transcervical resections of the myome. We use it for the submucous myome. You can see here, we can use the wire loop here with the energy source bipolar or monopolar. It depends what you have in your operating room or your private. Nowadays, we always use with the bipolar because it's quite convenient and quite safe. We can use the normal saline for distending medium. This one is the resections of the submucous myome. Yeah, for polyp, this one is mechanic with the, we can use the scissors. We can use the scissor to get the polyp here. Just cut it, the proximal one. And we can use the forceps and twist it to take the polyp out. Or nowadays we can use with the modulations like Bugatti Schaeffer's. It's quite convenient, but this is the simple one. So I think it's better to cut this way. Just cut the polyps. Okay. For tubal patency, is the most common for fertility checks. This one is the canal, cervical canal. This you see the gland here, and we come to the cervical os internal, and we come to the uterine cavity. Yeah, check or explore all the cavity, and we see the tubal os, fallopian tube. Okay, we insert the bubble. If the bubble can come through the tubal os, that means the fallopian tube is patent. Sometimes we can see the bubble with come out from the ostium here. You see that? Yeah, that one. Sometimes, yeah, you see the bubble. Yeah, that means the peristaltic of the tube. That means sometimes we can see that this one is also tube. The pattern tube, the tube is pattern. This one is the bubble. So this is the courtesy of my friend Professor Osama Shoki. Shato test. Okay. So what else we can see and treat? We can remove of retained products of placenta by resect it, or we can make hysteroscopy for metroplasty or septoplasty for the uterine septum. Yeah, we just cut it here. Or we can use for endometrial hyperplasia or dysplasia uterine bleeding. We can resect it with the wire loop. This one is we can use the monopolar or bipolar. With the advantage of the wire loop here, we can have the histologic or the tissue to send to the histopathologist to see what is the tissue. Is it cancer or just a simple or hyperplasia atypic? We can use with the roller blade. This one is the roller blade, just to ablate the endometrium, but we cannot have the tissue. So it's better if you want to see whether is it cancer or not, maybe the better is with the wire loop. Okay. And for tubal sterilization like Assure, this is the Assure with the hysteroscope, we explore the osteum, the tubal osteum, and then leave the oil inside. This one is for tubal sterilizations with the Assure. Okay. We can also see retrieve the dislots or translocations of the IUD, or sometimes we can see broken of the arm. This is the Mirena or IUD. Sometimes broken, we can find with the hysteroscopic and we can expel it out. This is my friends Sergio Jaimovic from Spain and Israel. This is the Bigatti, Giuseppe Bigatti from Italia. And this is my mentor, Professor Franklin Lover from Arizona, United States. This is my ISG friend, Bruno. And last but not least, this is the star now, our star stage now, Professor Osama Shawki from Cairo. Thank you very much. Okay, Professor Osama, the next speaker is you. Thank you very much.
You hear me?
Okay, I will your Professor Osama Shawki. Okay, Osama Shawki, Professor and Head of Unit Gaini, Cairo University, Director of Hysteroscopy and Training Programs in 36 countries. 36 countries. Yeah. Okay. We are the next. Hasanuddin University. Actually, you will come at March, but regarding to the COVID pandemic, so we postpone that. Maybe September, is it? What do you think? Okay. Inventor of many instruments. Oh, sorry. Stop. Okay, sorry. Yeah. Inventor of many instruments and equipments, laparoscopic and hysteroscopy, Karl Storz Company. Visited Indonesia 5 times. Conducted live surgery and lecture in Jakarta, Surabaya, Bali, Yogyakarta. And next is Makassar. Okay. Thank you very much. The time is yours now, Professor Osama Shawki. You are the star.
You have to close your screen, Eddie.
Yeah, already. Already?
Yeah. I want to be.
والله ما حضرتك.
Do you see me, Eddie?
Yeah, clearly.
Am I on screen now?
Yeah. Yeah, okay, already.
Okay, so I will start my presentation.
انا بس مش عايز اعمل شير سكرين.
Let me know when you see my presentation. I'm trying to share screen now for my presentation.
Not yet. Okay. Are you ready? Yes.
Tell me, are you ready?
Yep.
Assalamu alaikum. Everybody hear me? Say yes or no if you don't hear me.
Yes, we hear you.
Yes.
We can hear you.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
It is
Waalaikumsalam.
So before I start, I want to say salamat and terima kasih to everybody for joining me in this morning or this afternoon in Indonesia. And I promise to accompany you for a very entertaining, educational, exciting session about hysteroscopy. And as Eddie said, thank you, Eddie, very much for bringing me today. And thank you for Dr. Budu as well, Professor Budu from the university. We already established and signed an agreement about collaboration between my university, Cairo, and my Center for Training for Hysteroscopy, together with Makassar University. And we are planning to invite so many of the young fellows from Indonesia for training in Egypt. I visited Indonesia so many times. Everybody, do you see this picture?
Yes.
Okay, so I hope some of the audience today can see themselves.
Yeah, that's me.
Okay. And this was in the operating room. We had a lovely time in doing live surgery for many challenging cases in Jakarta Hospital. And this is some of my friends. You can see my friend Ichnandi. Do you see this picture? It's full of happiness, full of emotions and motivation. So I promise that all my fellows in Indonesia who will be trained with me, they will be so competent in doing hysteroscopy. And also this is some of the friends. Next. This picture also is full of happiness, and I think this was in Yogyakarta. Next. And I want to thank Eddie Hartono for making this nice webinar today. So, hysteroscopy. For a gynecologist, endoscopy means either laparoscopy or hysteroscopy. And the initial enthusiasm and interest of every gynecologist was for laparoscopy. Do you hear me well, everybody? Eddie, do you hear me?
Yes. Loud and clear.
As I said today, I want to discuss with you what should be the most important endoscopy for gynecology. Laparoscopy is playing inside the abdominal cavity. Hysteroscopy is inside the uterine cavity. So for gynecologists, both are important, but one of them is a must. One of them is essential for each and every gynecologist. I will not blame you if you are not doing hysteroscopy, if you are not doing hysterectomy laparoscopically, okay? So hysterectomy can be done open, vaginal, or laparoscopic. But for a uterine septum or a submucous myoma, there is no other option. It should be only hysteroscopic. So the message I want to bring today for all my colleagues in Indonesia, laparoscopy is a good option. So listen to my language. It is an option. It's a good option, okay? But hysteroscopy is not an option. Hysteroscopy is a must. So every gynecologist should know how to do hysteroscopy. But let us define or redefine hysteroscopy. This is actually not published. It is my vision. It is from my mind. Redefinition of hysteroscopy. Because people think that if I go to take a training course in hysteroscopy, to know how to handle the instruments, to go in and out, to remove a polyp, then I can do the septum and the myoma and the Asherman. No. Let me redefine. There is a big difference between hysteroscopy and intrauterine surgery. These pictures are hysteroscopy, which is diagnostic for infertility, for bleeding, a polyp, missed IUCD, And this is what's the meaning of hysteroscopy. And everybody should know how to do this. Even in some countries, nurses are trained to do simple office procedures. But intrauterine surgery is something different. This is all hysteroscopy, what you see. But this is an intrauterine surgery. The large myoma is not a hysteroscopy because the equipment are different. The techniques are different. The skills are different. And the complications are also different. So from now, I want every gynecologist to know that hysteroscopy is a simple procedure in the meaning of diagnostic, small polyp, and before IVF, before infertility treatment, for bleeding, for taking a biopsy. But for large pathology, like large septum or big fibroid, this is another skills. This needs more time. You need only to take a course of 1 week. In 1 month, you are competent to do most of the diagnostic and office procedure as a hysteroscopy. But to know how to do the big myoma and the septum, this is another story. Why I am saying this? Because every beginner start to learn hysteroscopy and know how to go in and out. So next day he wants to do the big septum and the myoma and he will fail. So please let us redefine. There is a difference between hysteroscopy and intrauterine surgery. Another point I want to discuss with you. People think that hysteroscopy, you use only the telescope to look inside the uterine cavity. No, this tool will have more wide applications in modern gynecology. To look inside the vagina, to see the cervix, the uterine cavity, and also the fallopian tube. So I will show you the technique of vaginoscopy, which I train people and spread all over the world, which is different than the meaning vaginoscopy published before by my friend Dr. Stefano Bitocchi, which in his article described a technique, no speculum, no teneculum, just to insert the telescope through the vagina directly to the uterine cavity to facilitate the technique and make it not painful for the patient. But in that description, they did not describe examination of the vagina. Examination of the vagina, which means that you look to all vaginal walls to examine the cervix by the telescope. Look at this. You insert and open the water, and that's vaginoscopy. So this is a new vision in gynecology. This is a modern way to examine the vagina better than using the cascospectrum. You can see all vagina rougée, you can see the cervix, external os, and endocervical glands. Let me show you something interesting. That's vaginoscopy, vaginal wall, cervix, and now you will see a surprise. Look at this. Everybody, look at that. Eddie, can you tell me what is this? What's your diagnosis?
Endometriosis.
Exactly, my friends. So we have never diagnosed vaginal endometriosis before because the examination by the cascospeculum or vaginal speculum will never give you this beautiful picture. So please believe me, please from now on, you have to change your practice in the office. Instead of putting this painful vaginal speculum, and then you cannot see anything well. So use the telescope and have this beautiful panoramic view. But sure, you will ask me, Osama, how can we have good distension of the vagina? It is very simple. First, you have to use a good fluid pressure. And then by your fingers, you can do manual pressure on the vulva. Just close the vulval orifice. Press with your fingers. So you will allow distension of the vagina and you will see this nice view. And you can see beautiful vaginal and cervical endometriosis. I will show also another application in the office. This is a case of a longitudinal vaginal septum. So you can see it very well in the office using the hysteroscope. Not only see, but you can treat. This is a vaginal septum, which was dividing the vagina into 2 halves. So using a monopolar electrode, you can cut all the way up until you unify the double vagina. So this is inside the vagina. You can see the landmark is external os. This is external os, another external os. The procedure is so simple, it takes less than 1 minute, and you do incision of a longitudinal vaginal septum with reunification. So this is another modern application. This is the vagina after reunification. Everybody see that? And the video is the real time. I mean, there is no editing. Eddie, what is the most frustrating problem in hysteroscopy for beginners?
Yeah,
They cannot see well. The view is like that. I call the view is the Japanese. Exactly, that's what everybody see. Okay, they see only a red circle, bloody, turbid. They cannot identify any anatomical landmark. Where is the tubal ostium? Where is the anterior wall? And these views are very frustrating. Look at this. I just selected some of the videos which show the unsatisfactory view. It shouldn't. If this is hysteroscopy, nobody will love to do it. It's very dangerous to cut in this view. It should be different. Everybody look now. That's the proper view at hysteroscopy. Panoramic vision, seeing very well the fundus, and you can rotate the telescope and you see the tubal ostium. You can see the endometrium, other tubal ostium, and even you can see the bubbles going. Look at the insertion from the cervical canal, Eddie. Yeah. Nice insertion. I'm going to teach you today how to do it. And you can see very nice a polyp. Everybody dreams to have this view. It is not difficult. It's not difficult to have this beautiful view for the septum. Cutting the septum is not difficult, but to have this view is a challenge. To have this beautiful panoramic view for the myoma is a challenge. So, Eddie, let me share with you the 5 rules to master hysteroscopic surgery. Rule number 1. Everybody learned first how to do laparoscopy. And then when you started to do hysteroscopy, you applied the same rule in holding the camera in your hand.
Golf.
Yeah. So golf and cricket are different in handling the bat, okay? I will now open the camera to see my face and explain to you. Do you see me well? عايز احط الكاميرا on my face. Eddie, do you see my hands or no?
No. Okay. Where's your hand?
You see my picture?
Yeah.
Yes.
This one? Yeah.
Suppose this is the camera.
Okay.
I want to open screen so you can see me well.
Okay, yeah.
You can see me now, okay?
Yep.
So if this is the camera, this is the camera controls, all right?
Yep.
So in laparoscopy, you hold the camera like this and move the telescope like that, okay?
Yeah.
In hysteroscopy, we are using a 30-degree lens. 30-degree lens. So the lens is looking up. If the camera rotated like that, if the camera rotated like that, the 30-degree lens will show you a very confusing view. The left become right and the right become left. So during hysteroscopy, you have to make sure that the camera never rotate during work. If you hold the camera like this, sometimes the camera rotate, but the lens is still straight, so you get confused. During hysteroscopy, we don't hold the camera like that. We hold the camera like this. You see this? Say yes.
Yes, sir.
So this is the way how to hold the camera. So in hysteroscopy, your eyes can see the camera control. So if any rotation happen, you can correct it. Another thing, in laparoscopy, to see left and right, we move like this, left and right, left and right. In hysteroscopy, no, you rotate like that. You see my hand? You see the rotation?
Yeah.
This is the secrets of hysteroscopy. It is not written in textbook, okay? So in hysteroscopy, you have to rotate the camera like this. So if you hold the camera this way, you will not be able to rotate. So the grip in hysteroscopy is different than the grip in laparoscopy. Laparoscopy grip is like that. So you can move left and right to see the lateral wall. In hysteroscopy, you hold the grip of the camera like this. So to rotate, you make like this and like that, like this. You see my fingers, Eddie?
Yep, very clear, sir.
This trick is $1 million trick, okay? This trick is 1 million, how to rotate the camera. So the grip is different.
That's one what you call Osama grip, is it?
Exactly, you can call it Shawki grip. And then, how to stand in front of the patient. You see this image, Eddie? This is a laparoscopic surgeon, okay?
Yep.
So you see that the surgeon is facing the monitor, and it is very comfortable operating like this, okay? But in hysteroscopy, look at this picture. Here the surgeon is putting the monitor on the side. So he is twisting his head. You see that?
Yeah.
This is wrong. You see this view?
Yeah.
So, okay, I think my pictures are very clear. So every hysteroscopist should move the monitor, should tilt the monitor, not to tilt his head. Because if you twist your head like this, you cannot operate a myoma resection for half an hour with this view. Okay? I can hear some lovely voices. I hope that they are happy, because all the tips I'm giving you now is not written in any textbook. All right? We come to rule number 2.
Yeah.
The size of the lens and the size of the telescope. For a long time, gynecologists were using the 4 mm lens, 4 millimeter. Today, we are using the 2.9, okay? So, if there is a big difference between 4 mm and the 2.9, Eddie, how much smaller, the 2.9 telescope than the 4 mm? Give a guess, 10%, 20%, 30%, exactly. So the difference in the diameter between the 2.9 and the 4 mm is 30%. So from today, we have to stop using the 4 mm for diagnostic hysteroscopy. It's large, insertion is difficult, it is 30% bigger. So insertion of a large telescope will do friction with the cervix, and this will make debris, bleeding, and you will not see well. Okay? This person is using in this video, this is a 4 mm, and you can obviously see that the surgeon is grasping the cervix with the teneculum, and then he is pushing the hysteroscope bluntly like a dilator. Look at this. And I will let my assistant to tell you what is the disadvantage of using it. Look at the video. Grabbing the cervix, pushing the telescope like boom. Okay. So now I will ask my assistant, are we doing this technique in our practice? Yes or no?
No.
Definitely no. Why? Raise your voice.
Mainly because of the traumatic effect on endometrial shreds it will produce, thereby occluding the view, because if you have a very small shred on the 4 mm or the 2.9 mm lens, it will cover even a 1 millimeter shred will cover 30% of the lens. You will lose 1/3 of your view. The second thing is it is causing trauma inside the cavity, leading to the shreds and blood clots, obscuring the view inside the uterine cavity, which is very difficult to rectify. Once it happens, you will continue your operation with a bad view.
So I want to now let my assistant tell you how we do it. Do we dilate the cervix before hysteroscopy? Never, never. So do not dilate, because dilatation by any Heger dilator or blunt insertion like this way, it will do friction with the endometrium, will create shreds, and you will not see anything because of the shreds and the blood. So tell me, my assistant name is Yahya Shauki, okay? He is my son. Yahya, how to overcome the cervical passage without dilatation?
By careful direction and by adequate fluid pressure, opening the cervical canal slowly. What happens is the fluid pressure enters, dilates the cervical canal. It goes inside the uterine cavity, and because there is no outlet, it will come back and automatically dilate the cervical canal. Combined with the direction, you can go in smoothly.
So I repeat what he said now. Your dilator is the fluid pressure. Do you hear this, Eddie?
Yeah, clearly.
Okay. So during insertion from the cervical canal, please use whatever possible pressure. I will not say number, but you have to keep it high enough so the fluid pressure will open the cervical canal. And then you will see the internal os, and then you will go slowly, slowly. So again, fluid dilatation, very slow insertion. You know, Eddie, I see all the beginners, they push the hysteroscope quickly to the cavity, the same like they push a Heger dilator or a uterine sound. If you go quickly, you will go inside the cavity before the distension. Let me repeat it. Please let the water go into the cavity before you enter. You get the point, Eddie? If you go quickly, without distension, you will do friction. So, again, this is a wrong way. No need to grab the cervix, and don't push bluntly like this. Boom. We come now to the third rule, which is the direction of insertion. Everybody see this image?
Yes, yes.
Yes.
This is a 30-degree angle, all right? So with the 30-degree, the lens will be looking up. So in insertion of the hysteroscope, you should be seeing the anterior wall of the cervix. If you see the internal os as a rounded circle like this, your direction is correct or wrong? You tell me.
Wrong.
Wrong. It is very wrong. If you see the internal os rounded circle, your direction is posterior like this. And if you keep pushing, you are pushing here, and you will make a false track or boop, perforation. Okay? So this is because of the fact of the 30-degree angle, your vision should be more up, not central. Look at this video. Everybody, do you see the polyp? Yes, say yes or no.
Yes.
Yes.
Okay.
Yes.
Yes. So you can obviously see that the telescope is looking up, up. You should not see the posterior wall. I will play the video. Look at this central view. If this is wrong or correct insertion now, can you tell me?
Wrong.
This is wrong. It should be like this. Everybody again. This is the correct insertion. Eddie, this is the most important video I showed. This is the correct insertion. Again. I will show you. This view is wrong. When it is central view, is wrong. And now you should have only a crescent view. This is correct. Like this. So this is how to insert nicely without friction at all. So for looking to the side walls and to look at the corners, don't move your hand from side to side. You have to rotate the camera. You cannot see my hands now. Can you see my hands or no?
Yep.
Yes.
It is rotation like this, okay? It is rotation like this. It is not from side to side, all right? So this is the movement. You hold the light cable and you rotate the light cable all the way around upside down like this. So you can see all the sides of the uterus. Look at this. Now you'll see a nice video. This mark is the side of attachment of the light cable, everybody. This notch is the light cable. This is the fundus. This is one ostia and other ostia. Let's see a video. Look at the notch. Look at the notch. Rotate. Rotate. Now you can see the lateral wall. You see this? This is the lateral wall. And the other lateral. So finally, to see the lateral wall, Eddie, you rotate the camera or rotate the light cable. Do you see my hand now or no? Tell me yes or no.
Yes.
Okay, if this is the telescope and this is the light cable, you hold the light cable and rotate the light cable like this and like that. So this is one way. The other way is to hold the camera in your hand and rotate the camera like this, all right? So either you rotate the camera or you rotate the light cable. So I could see in the morning the face of Indra, Dr. Indra from Jakarta. Is he still with us?
Semarang, from Semarang. Indra is from Semarang.
Indra, he has a very nice hospital and very nice IVF center. So Indra, I want to tell you, if you are doing diagnostic hysteroscopy, only diagnostic, you hold the camera with the left hand, you hold the light cable with the right hand, and you rotate the light cable like this and like that. When you rotate the light cable, the lens is rotating, so you can see the lateral wall. All right?
Yeah. Oh, yes.
Suppose now you want to cut a polyp. I want to now to examine a situation together. There is a polyp inside, and the polyp is on the lateral wall. You are holding the camera with your hand and the scissor with the other hand, okay?
Yeah.
You don't have a third hand to hold the light cable, okay? You got the point, Eddie? So
yeah.
You cannot hold the light cable and rotate. So if you are using the scissor with the other hand to look at the lateral wall, you rotate the whole camera. You see this? I hope you can see it.
Yeah.
Okay. So this is a very important advice. When you want to cut any pathology on the lateral wall, you hold the camera like this, the scissor with the other hand, you rotate the camera, and then you rotate the scissor. All right?
Okay.
Then we come, there are 5 rules. This is rule number 4, and it is the most important rule. You know what is the most important? Distension. You cannot do laparoscopic surgery without pneumoperitoneum. You cannot. If the abdomen is collapsed, the bowels and the uterus, you cannot see. The same for hysteroscopy. Without distending the uterine cavity, you cannot see anything. Pneumoperitoneum in laparoscopy is much, much easier than distension of the uterus. I want to tell you something. When you go for any training course for laparoscopy, in the lectures, they don't speak about distension and pneumoperitoneum, you know? Am I correct, Yahya? There is no lectures about how to do distension in laparoscopy because it's easy. It is standard. You put the needle, whoop, pressure is 15, and you operate. There is not much to say about. But for hysteroscopy, there are so many lectures about distension. You know why? Because we use different types of fluids. We use different pressure settings. And there is a lot of controversy how much pressure we need. In laparoscopy, there is nothing like this. So, if you are working with a very low distension pressure, this is the view. You cannot see well, all right? But if you're using a proper fluid distension, it helps you to enter the cavity and you can see the cavity. So this is a difference between lower pressure and higher pressure. I know it is a very controversial issue. عايز اطلع فوق اطلع السلايد اللي فوق لا طب اطلع بره اطلع بره exit. Okay, so Eddie, let me say something important. Do you see my face now?
Yeah.
Okay, let us now discuss the issue of the pressure by logic, not by science. Put the science now on the side. The arterial blood pressure, the mean arterial blood pressure is 100. If you measure the blood pressure is 120/80. So the average pressure inside the blood vessels is 100, okay?
Yes.
So if you are doing surgery for a septum or myoma, distending the cavity for a pressure less than 100, okay? When you start to cut into the septum or the myoma and the blood vessels are open, the pressure inside the blood vessel is 100. If the pressure of the fluid inside the uterus less than 100, can you tell me what will happen?
Bleeding.
Exactly. The blood will flow into the cavity. It is not a dangerous bleeding. No, it is not dangerous. The patient will not die from the bleeding. But some little blood with the distension fluid, everything will look red. And this is the big issue that I am fighting all over the world. And I have so many people who are criticizing my technique. They say, Osama is crazy. Osama is putting high pressure. Osama will kill all the patients. Okay, I've been operating thousands of cases, all right? And thanks God, I don't have mortality so far. The idea is for listen to me, this is the most important advice in the webinar. If you are only doing diagnostic hysteroscopy, or simple polyp, or extraction of a missed IUCD, you don't need a high pressure. Only little pressure to open the cavity. How much pressure? I cannot tell you. There is no number. I'm sorry, anybody saying numbers is a liar. Is a liar, is a fake. You cannot say 60, 80, 40, 100. This is all estimation, not correct. Because the uterus is a muscular organ. It has a thick muscular wall. And there is a difference between a small size uterus, postmenopausal, or multiparous uterus, or a fibroid uterus. So the pressure needed to open this cavity will differ. It varies from 1, 2, 3, 4. They are not all the same. So I cannot give advice to say pressure 60 is okay. No. You keep rising the pressure until that cavity is open. Sometimes 80, sometimes 60. Maybe a postmenopausal, very small uterus, 40 is enough. So there is no rule for the number. So if you are doing diagnostic procedure, any little pressure is enough, so long it opens the cavity that you can see well and take the IUCD out or take the biopsy. But, and I say but, very important what I say now. If you are doing major pathology, like a big fibroid or a big septum or Asherman, if the pressure is less than 100, you cannot operate. You will be cutting in tissues without having a view. Everything is looking red. Either you will perforate or you will not complete the surgery. I'm sorry to say, Many people say we can do surgery at a pressure of 80. They don't complete, you cannot remove the whole myoma. You will stop in the middle. The danger is once you increase the pressure above the arterial blood pressure, intravasation will happen. You understand what's intravasation? The fluid will go into the vascular channels. And if you give much fluid for a long time, you will end in fluid overload. And this might kill the patient. It is not like laparoscopy. Laparoscopy, distension with carbon dioxide, you can operate for 3, 4, 5 hours. There is no worry. But in hysteroscopy, you have to finish quick. Eddie, how to say quick in Indonesia? Quick, how to say?
Cepat. Cepat.
Okay, so in myoma surgery, septum surgery, unless you are competent enough to increase the pressure and see well and finish, then don't do it now. It is not for a young beginner or an average, all right? So the pressure issue, and I think one day the whole world will believe me that it is a fake to say we can do big surgery with a pressure of 60 or 80. Exactly, can you do TLH with a pneumoperitoneum of 8 or 10? You cannot. You have to increase the pressure to open the abdomen so you can see well. So this is about the fluid pressure. Yahya, come. So this is the difference in the view between low pressure and higher pressure. Let me now go to another advice or take how to do septum surgery. Do you see this image?
Yeah.
Okay. So this is designed by my assistant. Let me introduce this young, handsome man. Come down, down, down. Eddie, you are proud of your son-in-law, okay? If you are proud of your son-in-law, I am very proud with my sunshine, okay?
Yahya is my nephew too.
Okay.
Hi, Yahya.
Yahya,
sir, how are you?
Yahya practice with me. We work together, we operate together, we sleep in the same room, we eat in the same room, we exercise in the same gym. So he is the better copy of myself, right? So Yahya provided this slides to tell you technique how to do septum surgery. I will start, he will continue. To start with, when you dilate the cervix, Yahya, we have to be careful not to hit the septum. نتكلم على dilatation ونتكلم على slow insertion. So tell me how we do this technique.
First thing is to always, before the operative procedure, perform a diagnostic hysteroscopy with the minimal diameter hysteroscope. You go in very smoothly, very slowly, so that you know exactly where the apex of the septum is.
So you start by diagnostic, don't start operative. You use the 2.9 telescope. So first we use the 2.9 to dilate the cervical canal, to see where is the apex of the septum, to have the topography, and then we proceed. Next.
Following this, you perform dilatation of the cervix. It's very important to stabilize the tenaculum you are pulling the anterior cervical lip with, because if you're, for example, you are holding the tenaculum with your left hand and you are holding the Heger or the Hank dilator with your right hand, if your left hand gives way, if you are not pulling strongly and if you don't have a good grasp on the cervix, one of two things will happen.
So if you are not controlling grab on the cervix by tenaculum and you push the dilator without controlling the power, the dilator might boom and hit the septum.
Or the tenaculum will tear the cervix. Either one is not good, either one will cause trauma and damage, and you will have a less perfect procedure going forward. So adequate control of the dilator and the tenaculum, and be careful to not hit the septum, the apex of the septum with the dilator. So because you already know the topography from the diagnostic procedure, and carefully negotiating the internal os, not just dilating, negotiating means you get tactile feedback and your performance is changed according to that feedback.
That means very slow insertion. Eddie, everybody listen to me. Very slow insertion. If you cannot see, don't push. I can feel you, many of you, I can see your eyes. You get frustrated, you cannot see, and then you push. And when you push by force, you will hit the septum and you will not see anything after that. So as Yahya said, tactile. Tactile means your hand feel the resistance, a little bit push in, a little bit out, a little bit in, until you negotiate the surface.
If you go in diagnostic and then you fail to dilate, there is no problem. Take the dilator out, go in again with the diagnostic hysteroscope. This is the smallest dilator you will start with. This is a dilator. It will show you the direction and also dilate the cervix a little bit.
Okay, Yahya, we have to distend the cavity well, expand the cavity, and keep the septum, listen, stretched. How to say stretch in Indonesian? Stretch, stretch. Yeah. Okay, so how much pressure is needed? I don't know. I will be a liar to tell you if I know, all right? There is no number, because in laparoscopy, Eddie, when you do pneumoperitoneum, the abdomen is distended, there is no leakage. But in hysteroscopy, when you distend the cavity, there is leakage from where?
From the fallopian tubes.
Fallopian tubes?
From the cervix.
And from the cervix. So there is a lot of leakage. So you keep pushing the fluid. You have to use a good pump. And inshallah, a good news coming to the market by a pump designed to give you enough pressure to stretch the septum. And then?
Just regarding the problem with the pressure, because the very adequate physicists among us will know that regardless of the leakage, if you set the pressure at a certain number, then you should have that number inside the cavity. This is the same as we do in pneumoperitoneum. When you standardize 14, 16, 20 millimeters of mercury, that is what you get in the abdomen. In hysteroscopy, it's not like that, because even if you set the pressure to 180, because there is continuous leakage, it is very fast, there is always leakage, it will not give you the actual pressure inside the cavity. There is no pump on the market today which will give you the true intrauterine pressure. It will only give what is coming out of the machine. Now we go into the septum itself. There are 3 techniques for incision of the septum. It's not resection, it is release or incision.
Again, you don't remove the septum, you just incise.
The first technique, which was the first one adopted by hysteroscopists, was the picture you see, and then pushing the Collins knife, insert electrode anteroposteriorly, so or codocephalic, pushing it forward. This was the first technique. The second technique, when they found that this can lead to perforation and is slightly more dangerous, was pushing the loop almost at the level of the tubal ostium and then incising from cephalic caudal. Again, this is not optimal. It means you resect one side of the septum first before the other side. So Professor Shawki developed a third technique, which is a side-to-side movement.
So 3 techniques Yahya said. The first one that people use to push like this, or to pull like that, and then we designed our own technique. First, you should have a panoramic view. Where is the landmark?
You have 2 landmarks. The first one from the apex of the center, just apex of the septum, just divide the septum 50-50. 50% anterior, 50% posterior. And another landmark is the tubal ostium.
So this is the side-to-side movement that Yahya is speaking about. Side-to-side movement, and keep the tubal ostium your landmark. You see that, Yahya? Thank you for making nice videos for me. So the tubal ostium is your guide. It's your North Star. It's your GPS, which tell you where to move. And this is the final view. Everybody happy with that? So the question from all beginners, we cut till when? When to stop, Yahya? When to decide to stop?
2 points in when to stop. The first one is preoperative. The second one is intraoperative. Preoperative, you need a 3D ultrasound to measure the remaining fundal myometrial thickness. If it is adequate, meaning more than 3 to 4 millimeters, then in intraoperative, the landmark to stop is when both tubal ostia lie on one plane, one line.
Both tubal ostia, straight line. Okay? So, Eddie.
Yep.
Tell me what you see. What's your diagnosis? This is a septum or bicornuate?
This one is septum.
Some people will say bicornuate. So let me give you some hint. If at hysterography you find the angle, this is the angle between both corneas. This is one cornea, other cornea, and this is the angle. If the angle is acute angle, this is 100% septum. If the angle is open angle, this is could be bicornuate and could be broad septum. Here we have to do 3D ultrasound. So let me share with you now hysteroscopic metroplasty with a nice background music. Tubal ostium is here, and that's the septum. Look up, look down, stay exactly in the middle. Everybody, appreciate and observe the retraction. The septal tissues retract. Eddie, Yahya is criticizing me now. He is whispering in my ear saying that the pressure here is very high. Do you agree with him or no? He said that you are working with very high pressure here. It doesn't.
What is the pressure?
You know why I was using high pressure? Because the septum is very broad and very vascular. So I have to use a higher pressure till I finish. This is one tubal ostium, another tubal ostium. And then final adjustment.
What is the pressure?
Here is the fine touches of the fundus. Adjust the zoom and just cut. It is not excision, it is incision. In few seconds, you will see a final view. That's tubal ostium, and that's the septum release. And this is the enjoyment step when you have a post-operative histogram showing before and after. Okay. So far, everybody is happy. I'm almost finishing in 5 minutes. Are you happy?
Yes, very happy.
Yes, happy.
If you're happy, you have to invite me for lobster in Makassar, okay?
In Makassar.
Lobsters and prawns and fish.
Okay.
Okay. So now this is the last thing I'm talking about, the fibroid. This is the most recent classification for uterine fibroid by the FIGO. They put them into 7 categories. The type 0 fibroid, which is the submucous fibroid attached by a small pedicle, but all fibroid hanging inside the cavity. The type 1, more than 50% of the fibroid bulging into the cavity. The type 2, it's a deep intramyometral myoma with less than 50% bulging into the cavity. Type 3 and type 4, both of them are intramural, but type 3 intramural touching the endometrium, type 4 intramural touching the serosa. When it starts to migrate out, type 5, less than 50% bulging subserosal, type 6, more bulge, more than 50%, type 7 is pedunculated subserous, which is equivalent to the type 0 submucous. So this is the classification. And that's an example of type 0. You can see this is the pedicle, okay? Here you have appreciate the proper distension to create the space and start to cut. Another type 0 fibroid, enjoy this one. It will take only 1.5 minutes to finish the fibroid. It is not that the surgeon is fast. Anybody can finish it in 3 minutes, but you have to see well. Unless you have a good distension and you see well, you cannot finish. So most of big fibroids up to 3-4 centimeters, you can finish them in less than 15 minutes or 20 minutes maximum. You can see cutting into the myoma tissues. And this is the last part, the pedicle. Here is the pedicle. This video is all available on YouTube. You can check them. This is the base of the fibroid. And you can use the electrode to push bluntly, push, until the remaining part is detached from the attachment. And now you can see the myometrium. I'll show you the myometrium. This is some residual fibroid tissue. And this, you see this interlacing fibers? Okay. This is the final view. And this is a larger fibroid. This is about 5 centimeters fibroid. This is a challenging case. The challenge and the difficulty that the beginner will take longer time, and there is a big chance of fluid overload. So you have to work slowly, finish quickly. And when to know that you remove the fibroid and the landmark to stop, when you see the myometrium. That's the myometrium. Indra, where is Indra? Where is Ishnandi? Where is Este? Where is all my friends? Dr. Professor
Hi, Indra here.
I'm here. Of the fibroid. And this is the myometrium. Let me teach you. Myoma tissues are solid, white, like this. Myometral tissues are pinkish, interlacing, cross-crisp fibers, like that. So this is the fibroid tissue, and that's the myometrium, okay? So this is the myoma totally removed. And then, before I say goodbye, Eddie, do you hear me?
Yep. Yes, I hear you.
We come to the rule number 5, how to be good hysteroscopists. The rule number 5 is to learn from the best expert, okay?
You have to learn from an expert.
Yes. Learning surgery is not from textbook. I feel very sorry, Eddie, that most beginners and most new doctors, they think that they can learn endoscopic surgery by watching YouTube channel. No, YouTube are not made to learn the skills. You have to learn in the operating room. You have to see my hand. I showed you the little tricks in the hand. You cannot see this in YouTube. You have to stay in the operating room.
Yeah.
And that's the purpose. I visited more than now 56 countries to work together, to stay in the operating room. I hold your hand. You will feel the power of the hand, okay? The degree of rotation. It is not like this. It is not like that. It is very little fine movement. Unless we touch our hands together, you will not get it. So I'm very happy that Professor Budu and the staff of Makassar University has already signed an agreement collaboration with Cairo University. You will come to me, I will come to you, we will work together, and you will get all the skills. And you can visit YouTube. I'm very happy, Eddie, that I reached almost 2 million viewers so far. So please go and watch my videos more and more to have more viewers. It's for free. You don't have to pay any money. You can watch all the procedures. Just type Osama Shauki and septum, fibroid, polyp, Asherman, anything. You will find more than 2,000 videos, which was watched by 2 million viewers. I visited so many countries. I love people. It's not I love the country. I love the people, okay? I don't travel just to see mountains and oceans and the beaches of Bali. No, I love the people who live in Bali. I love the people who live in Jakarta. So I promise we work together. We will train together to improve our skills, to improve the quality of life we live, and to be more happy. Before I leave you, I want to tell you that the disaster of Corona makes the whole world sad. But believe me, It is just sad days, not sad life. So we have to be patient. We have to be faithful that these sad days will finish. When you have toothaches, Eddie, toothache, you cannot sleep the night, you cannot eat. You feel that life is black and time is not passing and you are angry, crazy. But when you get cured, you forget the pain. So my friends, the corona disaster is just a toothache. It will pass away. And at the end, you know the rules, you start training, and terima kasih everybody. Thank you very much. I love you all.
Congratulations, Osama. Congratulations, Eddie.
Okay, thank you very much. We come to the question and answer. If there are any questions, you can raise your hand or just write your
Eddie,
questions in the chat.
Any question is allowed except one question. They are not allowed to ask me, how old are you?
Okay. Is there any questions from the participants? Or you can just write your questions in the chat room. Okay.
My messenger is open 24 hours. My WhatsApp, you can ask me anytime. If any Dr. Eddie has did a procedure like hysteroscopy and he's not happy, he can upload the video to me. I will watch and I will advise him what was wrong and what was correct.
Okay, the first question is from Noviana Indarti. Nice lecture from Mr. Osama. If I want to follow short course of hysteroscopy with you, how long, and should I go to your clinic in Cairo?
Okay, I will answer this question. If you want to learn how to play golf, you have to buy the bat, okay? So you should have your equipment. And then you take a course, you go to take a course with an instructor. 3 to 5 days are enough to teach you how to hold the golf, how to make the swing. But 5 days are not enough to make you Tiger Woods golfer, okay? So my advice for you, each and every gynecologist should have his own office hysteroscope. It is not expensive, Eddie. I was in Indonesia, they sell it very cheap price, the 2.9. You have to buy your own hysteroscope. Then join my courses. I will come to Indonesia, Yogyakarta, Makassar, each Nandi will arrange for me in Jakarta. So when I come, you stay with me 4 or 5 days. If you want to come to Cairo, just make a group of 10 to 12 doctors and arrange to come with us. We will arrange with Dr. Budu to come to Cairo University. So staying together for 5 days is enough to start. And then with your telescope 2.9, alone in your place, any case of DNC, just go and look. You understand? Before DNC, just go and look. So you will have a chance to do many times in and out until you. Okay, so this is how to develop your skills. Start by diagnostic, biopsy, any infertility, any dysfunction, uterine bleeding, any miss the IUCD, you have to take it by the hysteroscope. And this is not difficult, no complication in that, all right? So this is the way how to develop your skills. For the big fibroid and the big septum, not today. Please, not today. Otherwise, you'll make a complication, I will not be happy, all right?
Okay, thank you. Any questions? Any more questions?
Osama.
Hello.
Dr. Eddie.
Okay, Nandi. How are
Nandi's
you?
here.
Hi.
Yes, I am. How are you?
Where are you? Where are you? Yeah, he is here.
I forgot the time difference between Jakarta and Makassar. Sorry, my mistake.
1 hour.
1
I
hour
miss
difference.
you very much, Nandi. I miss you very much.
Yes, miss you guys also. And then, Prof. Osama, maybe regarding there's a lot of us is seeing your lecture today. That might be a question that what size of resectoscope that you use? You know that the Gubini has the mini hysteroscope, resectoscope, which me, Eddie, and then Indra use it very well. And then, but for the general of us, what size of his resectoscope that we should try first? Is it the big one or the smaller one?
That's a very good question. Let me answer it in 2 points. Point number 1, when you buy Hager dilator for the operating room set, do you buy only one dilator size or you have the whole set?
Whole set.
You have the whole set. Hager number 6, 7, 8, 9. Am I correct?
The whole set.
You got this point. So you cannot have one size only. The other question, I know that you love to eat.
But
apple.
It comes from the 1990s, yes.
Okay, if you are eating an apple and a watermelon, how to cut the apple, which size of knife to cut the apple, and which knife for the watermelon.
Karena ini, nggak ada video nih.
You cannot use a small knife, Swiss Army knife, to cut a big watermelon. You got the point, Eddie?
Yeah.
Okay. Otherwise, you will take longer time and it will not cut. So, my answer for beginners who will deal with only small polyp, short septum, they can use the small Gubini resectoscope. It's okay. It's a 15 French almost. But if you are dealing with a big pathology, you cannot use the small one. So that's why Gubini is angry with me. He say, Osama, why you are not using my resectoscope? I say, because I don't see any small cases. All the cases come to me that the people they don't want to do, the large fibroid, okay? So I cannot use the Swiss Army knife to cut the big knife. Did I answer your question correct?
Yes. So it's a good recommendation for you, and then for most of us who just try our beginning practice in hysteroscopy, try with a small one, and then try with a mini hysteroscope, and then actually in Jakarta, usually for practicing the office, I always ask my fellow to come to the OT and do the office hysteroscopy in my laparoscopic patient.
Exactly.
So the patient will be anesthetized, and then people will get to know the area and the anatomy very well, and then they do have the courage to do it in the outpatient setting.
The people
just
think
like the way you taught me.
Yeah, people think that office hysteroscopy is easy, so we do it in the office, and then we go for the operating room. No, you have to do it in the operating room when the patient is anesthetized and comfortable, and then you play until you master how to go in and out, and then you can do it in the office without anesthesia.
Yes, yes.
I think Dr. Indra has a very nice setting for office hysteroscopy in his clinic. Actually, I was so much impressed, and it is very well equipped. There is a nice examination chair, good light, good equipment, but if he needed to give some sedation, it's still available.
Yeah.
Okay.
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 Yes.
This
Let's
is
hope for September or October to have the visit or training course in Makassar. And if everything will go fine, inshallah, we will make it like a hysteroscopy carnival all over Indonesia, inshallah.
Yes.
One more questions, Osama, from Sultan Chandra. Hi, Prof. Osama. When you are doing the resectoscopy of fibroid, which setting or irrigation pump are you use? How high the intrauterine pressure, then how fast the fluid flow?
Nandi, can I answer this question, or it will cause a political problem for me?
No, the one who asked is one of my fellow. It's okay.
Eddie, if this webinar is confidential, I will tell you a nice story. Once upon a time, in a very big congress in Europe, the biggest congress of endoscopy in Europe, they make a session about debate. Two speakers. One speaker talking about high pressure hysteroscopy, and the other is about low pressure hysteroscopy. You remember that, Eddie?
Yeah.
It was each Nandi speaking about high pressure. Actually, I dislike or I hate to say high pressure. I call it the proper pressure. Is the proper
pressure.
It's not high or low. It is not high or low. It is the proper pressure, which is enough to open the cavity, expand, so you can see the fibroid and you can move left and right. If the cavity is collapsed, you cannot move by the resectoscope. So you have to expand the cavity and then you start to cut. If you are cutting and some bleeding is happening, this means that the pressure is not enough to tamponate the bleed. Little bleeding with the glycine or with the saline, everything will be looking red like the Japanese flag. So you increase a little bit more, all right? And then you have to finish in a short time. About the fluid overload, I will give you some nice advices. During the surgery, ask the anesthetist to look here for the patient, the parotid area and the jugular. If there is some swelling in this area, this means start fluid overload. If the jugular became congested, you have to stop, all right? And definitely oxygen saturation should be monitored. So there is no number for the fluid pressure I can say. One more time, one more very important thing, my friends. In laparoscopic surgery, you do pneumoperitoneum and you start to operate. Very rarely, you have to decompress or open the outflow, very rarely, if there is more smoke. But in hysteroscopy, all the time, this is the secret of my good videos, that all the time I play with the in and out. While cutting and operating, some tissue debris, some little blood will make the fluid turbid. If you keep working like this, it becomes more and more turbid and you will not be able to finish. So you open the outflow halfway or full way. The perfect hysteroscopist or the magician hysteroscopist who know how to play with the outflow and inflow. So you keep the view clear. This is a $1 million advice, all right? You are taking all the secrets today. So you have to play with the inflow and outflow, and all the time playing with the cavity. One more thing for the myoma resection. If you are cutting into the myoma and there are some tissue floating, many people like to go out, clean, and go in again. If you do this and go in again, you will see nothing. The view is very bad, lot of floating tissues, and you cannot identify. So as much as possible, don't go in and out, in and out, in and out. Keep inside. Cut, 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 cut. If there are so many floating tissues, Nandi, yes, with the power of fluid, push the fluid to push away the
debris.
Exactly. Push it to one side. It's not easy. It is like playing with the balls with the flash of water, okay? Push the strip to one side and keep cutting. If it has become very, very crowded, then you can clean. So there are so many things to teach in hysteroscopy which cannot finish in one webinar. And so many things not written in textbook. That's why my lecture in the European Society next year is titled The Untold Story of Hysteroscopy. What people don't tell you, right? They just see, they teach you this tension pressure should not be more than 100. And then they don't explain to you how. How can you see well? And how you overcome the leakage from the cervix. Sometimes the cervix is leaking. If you keep the pressure 80 and there is a leakage inside, the cavity will collapse. Do you agree, Nandi, or you have some point to tell?
No, I agree very much. Because sometimes we can increase if we close the outflow, there will be increased pressure in the cavity. And then everything will be more clearer. And then it's also useful if you have a bleeding. The increased pressure will stop the bleeding. So the point is how to get your view is an adequate view. Otherwise, there's no need to perform hysteroscopy. Yeah.
One little advice, if you start to have some little bleeding while cutting into the septum or the fibroid, two things you can do. This is a special compliment to you, Eddie, this advice. If you have some little bleeding, first you have to come close to the bleeder. When you move the telescope, enough, okay. If not enough, increase the pressure. So 2 maneuvers you do to control any bleeding. You come close and you increase the pressure. Do you hear me?
Yep.
Yeah.
Okay.
Yes.
Thank you. We come to the end of the session. Okay.
The good news
Any more?
before I go for you, Nandi, wish me luck, inshallah, inshallah. Probably there is some good news about a new concept for pressure pump. It will be accepted globally, inshallah. Wish me luck, inshallah.
Inshallah. Okay, we come to the end of the sessions. The conclusion, hysteroscopy is still mainstay procedure to treat intrauterine pathology and considered as a gold standard. Excellent hysteroscopic procedure would require good visualization of intrauterine cavity. This could be achieved by administering appropriate distension media, maintaining appropriate intrauterine pressure, and meticulous techniques. Okay, thank you very much, Professor Osama Souki, the magicians, and all participants. Thank you very much for attending this international webinar. Okay, thank you very much.
Okay, thank you, Eddie. Congratulations,
I'm waiting
Eddie.
the lobster in Makassar, Eddie.
Congratulations,
Lobster big size, okay?
Sorry, photo, group photo. Okay.
No group photo.
Okay. Please, all participants, activate your video. Activate your video so we can have the photograph. Okay.
Okay.
All the participants, please activate your video. Okay. 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 1, 2, 3. Cheers. Okay, the next. Okay, the next. Udah kasih tahu. Okay.
Thank you very
One
much.
more. 1, 2, 3. Cici. Hi. Okay, Nandi.
How to say smile?
Yes,
in-
Doctor.
Smile.
How to-
Cheers.
Cheers, senyum, ketawa.
Senyum.
Yo,
Congratulations, Soki.
Say hello to Rita and the girls, okay?
Yes. One more. One more. One more. Okay. 1, 2, 3. Cheers. Okay, another group. Okay.
Dr. Eddie, Yahya is not here.
Where is Yahya?
Where's Yahya? Yahya, come on.
We went to the gym.
Okay.
Oh, the gym.
Go to gym. Okay, 1, 2, 3. Cheers. Okay, thank you. Another
Thank you,
one.
Eddie.
Yeah,
Thank
another
you,
one. Okay. Okay, 1, 2, 3. Cheers. Okay, thank you very much. Okay. For all the participants, you can get the certificate after these sessions. Just mention your email address. Okay, thank you very much, Osama. See you next September, maybe. Ciao.
Ciao.
Thank you, Nandi. Thank you. Semua.
Aduh, Dok, sorry, Dok.
Terima
Lupa
kasih, nggak
banget
apa-apa.
beda waktu
Prof.
Jakarta Makassar.
Prof Wahyu juga ada di sini. Saya belum lihat ini. Prof Wahyu di mana? Saya terlihat terdaftar tadi ada kok. Oke, terima kasih semua. Thank you very
Ya,
much.
terima kasih Hartono. Terima kasih Dr. Hartono.
Terima kasih, Prof. Semua.
Terima kasih. Prof, terima kasih Prof Budu. Prof Sahrul.
Ada Prof Syahrul juga.
Ya. Dr. Trika, Ketua POGI, terima kasih.
Terima kasih Dr. Edi.
All staff, oke, Prof Sahrul, terima kasih banyak.
Dr. Indra, terima kasih partisipasinya.
Terima kasih semuanya.
Oke,
Semua
terima kasih.
sehat-sehat, bisa kembali berkumpul.
Terima kasih banyak. Amin. Oke, Nandi tambah sehat ya, tambah gemuk ini, apa tambah kurus nih. Tapi rambutnya kok bisa tetap bagus ya rambutnya. Di mana nyukur ini? Saya sudah lama nggak dapat tukang cukur ini.
Yang motong istri, Dok.
Enak ada tukang cukur.
Iya.
Oke, terima kasih semua. Terima kasih Dr. Rina, Vice Dean. Terima kasih Pak Ala Awal. Terima kasih Hairul. Oke, terima kasih Tina. Terima kasih semua. Terima kasih. Oke, see you.
Terima kasih, Dok.
Thank you very much.
Terima kasih, Dok.
Terima kasih.
kasih dokter.
Makasih dok. Dokter Leoni. Dokter Leoni apa kabar?
Iya dok, baik dok. Apa kabar dok?
Dokter Leoni. Ya. Halo. Umur berapa sekarang?
1 tahun dok.
Berapa umurnya?
Dokter Leoni semoga semakin sukses jenjunya.
Iya makasih.
Terima kasih di sana.
Sehat ya.
Ya, dok. Iya dok, sehat-sehat selalu dok.
Mari dok.
Kita saling menginfo, siapa tahu biling-biling dana ikut tahun itu.
Terus apa? Baru-baru tahu berarti Dik? Iya. Diri, assalamualaikum, terima kasih semuanya. Ya.
Aku tahu nggak tadi Sophia? Ya tapi seperti ini wajahnya. Tadi itu nanti Sophia bisa mati dong. Masalah ini gimana? Tapi nggak bisa. Bener dong. Gimana? Gimana?